Francisco, Scott, David, and I would like to welcome you to the 2022 PULM sessions featured on littlearms.org as well as on its own YouTube channel. Please see any of these sources for the additional videos listed here. I'm going to talk today about the principles of nerve injury and reconstruction. These are the two places where I'll be working starting in February, which is Philadelphia at Shriners and then the Hospital for Special Surgery. All right, so in terms of principles, we're just beginning to understand really nerve anatomy, what the injury is and how to quantify it, even qualify it. Nerve physiology, diagnostic studies that we can use, surgical options, and even rehabilitation. So I think it goes back to even very, very basic things, like what is the brachial plexus? So I grew up thinking that there were about 20,000 axons per root, or about 100,000 axons total coming out of the brachial plexus. It turns out that that is not accurate. There are about 350,000 axons in the cervical spinal cord that innervate the upper limb, passing through the brachial plexus. And a shocking only 10% are motor neurons. That's about 35,000 axons. And in all nerves that were looked at in this study, with the senior author being Oscar Osman, sensory axons outnumbered motor axons by a ratio of at least 9-to-1. That's a huge sensory bias. And the sensory axon contribution actually increases as you move distally. There are under 2,000 motor axons that reach the hand to innervate the intrinsic musculature, just to give you an idea. Other things we don't really understand are the degree of injury. We've had this SEDEN classification for a long time, and we know these categories, and we throw these names around as if they mean something. Neuropraxia, which means that there's a myelin injury, right? Because the myelin is most sensitive, recovers spontaneously within 2 months, we say. And then axonmetric injuries, where you have axons that are torn, but the nerve structure is in continuity, classic being a crush injury. And then we say that recovery is time dependent. We throw these numbers around like 1 inch a month or a millimeter a day, which is not exactly accurate and is age dependent. Then you have neurotmesis, which is where the nerve is cut or torn, and we say that there's no recovery without surgical intervention. And then to put a little finer point on it, the Sunderland classification breaks down neurotmesis into 3 separate categories. And you have whether or not you have endoneurium preserved, perineurium preserved, or epineurium preserved. That gives you a degree of neurometric injury. Now, the problem with the Sunderland classification is the analogy is like trying to convey the casualties of a battle with a broad classification. So imagine going to the president and giving this report, and you say, all the soldiers are mildly wounded, or all the soldiers are severely wounded, or they're all dying, or they're all dead, right? That's an impossibility. Casualty reports look like this. You have the number of injured, and then you have the number of killed, sort of your axon injuries, and then your nerve disruption, right? And you have a certain percentage of lethality of war wounds. Interestingly, that's been going down over the years. But it's this percentage idea. You can't talk about a nerve injury as saying all of the axons have been torn or all of the axons are demyelinated, because that just never happens. Injuries don't happen like that. In reality, neurotmesis, axonmesis, neuropraxia, these are flawed terms. They're oversimplifications. And what we really need to think about is what's happening on a micro level to understand what's happening on a macro level. And so it's much better to think of percent demyelination of intact axons, or percent demyelination. Percent of intact versus non-intact axons, a term from Tessa Gordon called axotomy. So the percent of axotomy, or actual axon disruption. And then the percent of how much macro and microstructure you have intact, so that the axons that have been axotomized can find their way back to their target organ. So the analogy again is like a rope. You're not going to cut every fiber all at once, particularly with a tension or a strain type injury. And not only on the macro level of the nerve itself, but even on the micro level within the axon. You can see in this drawing that the microtubules within the nerve, within the axon itself, don't tear all at once. And so you have a scenario where the demyelination is occurring, axotomy is occurring, and structural damage are occurring. And they all occur at different strain levels, but they all overlap. And so you have this concept of this percent injury, percent demyelination, percent axotomy, percent structural damage, that if you think about a nerve in this way, it will give you a better idea as to what's going on and help you understand your nerve conduction or electrodiagnostic tests in general. So here's a graphic. Here's actually a immunofluorescence representation of this. And you can see on A, this is an intact nerve. You can see an elastic strain to the nerve, and you see that most of the axons are still intact, although some have been demyelinated. And then you can see an inelastic injury where things are starting to look worse, and then a rupture that's allowed to heal, which looks even worse than that. And you can see this more clearly on the axial cut. And you can see the sham at the very left with proximal and distal to the injury looking about the same. And then you start seeing some changes with elastic, but you can see there's still some myelinated axons there and some no. And then as you get to inelastic strain, you start to see a greater loss of axons, but there's still some myelinated axons that make it through. When you get to a full rupture, very, very few myelinated axons remain. And this is represented here. And you can see between the elastic and elastic, there's a big drop in axon count, but it's not zero. And even in rupture, it's not zero. So I think this percent concept really gives you an understanding of what's going on. The myelin itself, when we talk about remyelination of intact axons, what are we talking about? The myelin itself is very sensitive to stretch, and it's the beginning of that curve. It's the first curve going up. And the injury results in Schwann cell resorption of myelin. What happens is Schwann cells transform from a supportive cell to a phagocytic cell by dedifferentiating. And they recruit macrophages also to assist with myelin degradation and phagocytosis of any cellular debris from any axons that have been torn. And then after about 3 days, T cells arrive and begin an inflammatory cascade, which is where we think some of the immune modifying drugs may actually help with nerve regeneration. Schwann cells remyelinate then the bare axons that remain that are not axotomized. But macrophages can persist in the nerve for 2 months, up to 2 months. And so the process itself takes about 2 months, and not all axons remyelinate. Some axons just never, for whatever reason, remyelinate, and those axons go on to terminal degeneration. So moving on down the injury scale, axotomies, right? 3 to 4 weeks after injury, the nerve has undergone Wallerian degeneration. And what does that mean? Wallerian degeneration has cleaned out via a combination of phagocytic Schwann cells and macrophages, have cleaned out the endoneurial tubes of all inhibitory factors that prevent nerves from or axons from entering that endoneurial tube. That's critical for the growth cone of the nerve to follow down the endoneurial tube. The proximal Schwann cells will then cross the injury site, and the distal Schwann cells dedifferentiate and begin to lure the axon. So in addition to a phagocytic role, they also have an attractive role. Axons begin to grow out. In the first 10 days, just a few, and they wait to see sort of how the water has been tested by the other axons. And there's no directional bias. Some go backwards, retrograde up the nerve, some go sideways, and some go distal. There is no functional bias either initially, meaning the axons just go out and find any endoneurial tube that they can find. This is represented here in this study, and you can see by 3 hours, the growth cone in vivo and in vitro is already starting to occur in a rat model. And then you see Schwann cell proliferation within 24 hours. Then phagocytosis by the Schwann cells begins right after that, about 2 days. By 3 days, you have the macrophages, and then the T cells are starting to come in, which are peaking at about a week. And the axons don't regrow as a single process. We talk about a growth cone, but it's more like a growth mop head, right? So our terms are kind of flawed in how we refer to this. These little tendrils go out, these F-actin bundles go out and sort of feel around chemically what's going on in the microenvironment, and they will try to go into whatever is most favorable. So once they sense that that they're in an endoneural tube and they latch onto the laminin, that's when they start really moving forward. And these growing axons then begin growing out to the target muscle. There's minimal function at first, as only a few muscle fibers are really contacted. And this is because not all nerves leave at once. There's some really great work being done by Greg Brachial and others looking at trying to get all of the nerves, all of the axons, I mean, to leave at once. And that it turns out that electrical stimulation may actually encourage growth of all of these sort of growth mop heads out all at once, rather than waiting for some to go before the others move. Now, once the nerve actually, once an axon contacts a muscle fiber, the motor unit begins to expand, and hopefully strength improves or recovers. And this timing is proportional to the distance traveled. But the millimeter a day thing is wrong, because it takes a long time for the axon to start really affecting any meaningful contraction of the muscle, because it has to expand in order to do so. And that takes a long time as well. So our timing is a little bit off, but the timing is affected by age and comorbidities. And what do we mean by expansion of these motor units? Well, a motor unit is one axon and up to several hundred muscle fibers that are widely distributed throughout the cross section of the muscle. It's not like one axon takes care of a bundle of muscle fibers. It's actually widely distributed throughout the nerve, throughout the muscle belly itself. Normally innervated muscle, only 4 to 6 muscle fibers of any particular motor unit are within the pickup range of an EMG needle. So when you see a little spike or a motor unit on an EMG, on a normal motor unit, it's only 4 to 6 muscle fibers that you're seeing, and that's why you have a low amplitude of only about 2 millivolts. Partial denervation, which means you have a partial axotomy injury. If you give the injury time for terminal sprouting and nodal sprouting to complete, you can get amplitudes of up to 20 millivolts. So what does that mean? These larger amplitudes suggest that some of the axons can expand to control 5 to 10 times as many muscle fibers within the range of the EMG needle, compared to what they did prior to the injury. So what's happening, right, on a micro level? If you take, for example, these myelinated axons, muscle fibers, and these perisynaptic Schwann cells, if you exotomize one of the axons in the region, that will denervate this muscle fiber. Well, the perisynaptic Schwann cells are then begin to search for viable axons in the area. So as long as you have some viable axons nearby, they will induce perinodal or perisynaptic sprouting or terminal sprouting into this denervated muscle fiber, and thereby reinnervate it, but you do it with fewer axons. So your motor units expand. With fewer axons, you can cover the entire nerve, and you can lose up to 80% of the axons to a muscle and still have normal function because of this phenomenon. So the timing and likelihood of recovery is tied to the injury severity, but hopefully we have a sort of a deeper understanding of what's actually going on. The remyelination of the intact axons is complete first. Then while the remyelination is occurring, the axotomized axons are beginning to grow out from the injury site. And again, this is age dependent, it's microstructure dependent, right? The less microstructure injury you have, the more likely it is that the axon is going to find an endoneural tube on the other side, particularly if its own endoneural tube is still intact. It'll just grow down its own path. And these then remyelinate as they grow out. And the intact axons, again, the ones that have not been axotomized, are undergoing terminal and nodal sprouting to increase their control to create larger motor units. So the intact axons expand within their target muscle, and they cover about 5 times as many normal muscle fibers. And the process, this whole process starts within 2 days of terminal and nodal sprouting, and takes about 3 months to complete if you have 100% of your axons intact. How do we know this? Well, we have a great model with Botox. If you Botox a muscle, you actually kill the motor end plates permanently. And the only way to recover is terminal and nodal sprouting. It begins within 2 days in the case of Botox, and it lasts about 3 months. An 80% axotomy injury takes about 4 to 5 months as you're expanding the motor units. So we talked about this disruption of the endoneural tubes. Again, it's not an all or nothing. Go back to the rope analogy. Some of the endoneural tubes will be intact. Some of them will not be. Some of them will be widely, disparately detached, and some of them will be very close. Some of them will line up, and some of them will not. There's this great study by Hoke looking at Schwann cell expression between motor and sensory Schwann cells, and it turns out there used to be thought that there were only 2 types of Schwann cells: the ones that are remyelinating and the ones that do not myelinate. So myelinating and non-myelinating Schwann cells. Well, it turns out that there are actually 2 subtypes of myelinating Schwann cells. There are motor and sensory phenotypes, and these regulate axon regeneration. And this is almost verbatim from their study. Schwann cells of cutaneous nerves and ventral root exhibit differing growth factor profiles at baseline, and they respond differently to denervation and reinnervation by cutaneous and motor axons. So what does that mean? That means that they have a preference. These Schwann cells actually help guide and bring in sensory fibers for sensory Schwann cells and motor fibers for motor Schwann cells. And these cell phenotypes, in addition to surviving the cell division or the proliferation that accompanies Wallerian degeneration, so they maintain their cell type and their difference after Wallerian degeneration. In fact, they're resistant to prolonged contact with axons of the opposite phenotype. So even if you put a sensory axon, an afferent axon, into an endoneural tube that has sensory Schwann cells, motor Schwann cells, those motor Schwann cells, when you remove that axon, will actually go back to being motor fiber or motor Schwann cells. So there's a strong record of initial association with motor axons that persist for at least a month, despite a challenge by heterologous reinnervation. The problem is that for the past century, we've been using cutaneous nerves, right, sural nerve, almost exclusively for clinical nerve reconstruction, for grafting. And so this may help to explain, as the authors say, why the results of grafting motor nerves consistently lag behind those of end-to-end nerve repair, but there may be other factors. And then one of the other things that takes a long time is if you misalign. So if there's no cortical, if the axons are returning to their original targets, meaning there's been no or very little endoneural disruption, then you don't require any cortical plasticity because all the axons have gone back to their targets. But you do need cortical reorientation if the endoneural tubes are misaligned. And this process can take months. And it's worse if the sensory and motor are misaligned, because now you're getting afferent signals coming back to the brain when all the brain wants to do is send efferent signals. And this is age dependent in terms of how plastic the brain is and requires cortical pruning and reassignment. We've seen in the case of brachial plexus injuries, this concept of co-contraction. And some patients may never recover independent muscle cortical control. So co-contraction of the biceps and triceps is common, and we will Botox these. Early repair is better than late repair, and the distal stump degrades, neuromuscular junction degrades, muscle atrophies, the ends retract, the ends scar, and it's more difficult to align correctly. Primary coaptation is better than graft. Why? Because the axons can be misdirected at each junction, and the axons may not cross the site, and the distal stump begins to behave like a late repair. Here's an example of a rat study looking at delayed versus acute repair, and you can see down by the 3 and 6 months that it's a big difference, statistically significant difference in the number of axons crossing. If we are going to graft, what type of nerve conduit are we going to use? We have Autograft, we have Allograft, and we have collagen and biomaterial tubes. Within Autograft, there's also what type of tissue are we going to take? Motor, sensory, mixed nerves. Allograft has some advantages, like intact micro and macrostructure, and there's no sensory or motor bias. So the Hoke problem is gone. And collagen biomaterial tubes also have no sensory or motor bias. And they really function to contain the outgrowing neuroma because they don't provide the microstructure. So allograft compared to conduit, the benefits are that the micro-macrostructure of the nerve is intact, and we do see as a result better clinical outcomes in gaps of greater than 5 millimeters. On the con side, allograft is more expensive, it's less available, and requires a freezer with cold storage of the allograft. When you look at allograft compared to autograft, the benefits are that there's no cellular debris for the nerve to undergo Wallerian degeneration. There's no inhibitory factors. There's no preference for afferent fibers, which you would get with using an autograft that has sensory Schwann cells. And there's no immediate metabolic demand, meaning you don't have to have a good vascularized bed in order for this to function. And there's no limit of availability. You're not going to run out until the company runs out of material. Unlike autograft, where there's certainly a limit to how much sural and even medial endobrachial cutaneous or lateral endobrachial cutaneous you can take. The downside, and this is a big downside, is what you see below. There are no Schwann cells. Now, allograft, as a result of that, is the gold standard. We mostly use sural nerve, which again is a pure sensory nerve. But there is no other conduit that performs as well over gaps of greater than 15 millimeters. And I think that's really important for everyone to understand. It requires imbibition and osculation as well, same as a skin graft, right? It requires a good vascularized wound bed, and please do not wrap autografts. You are preventing revascularization of your nerve autograft, and that is a mistake. What we see with allograft is that the Schwann cells are critical to success in gaps greater than 15 millimeters. Why? Because of this, the macrophage, and general inflammatory cascade as well. But I'm going to use the macrophage as a stand-in for the whole system. And really, it's a race between macrophages and the inflammatory cascade and the Schwann cells. One is destabilizing and one is stabilizing. The Schwann cells are moving in from the proximal side with their growth cones. The Schwann cells are also moving in from the distal side, from the distal stump. And from the outside are the macrophages. And the macrophages are degrading your allograft if it's not stabilized by your Schwann cells and the nerves therein. And if you lose, this is what you get. This is macrophages 1, Schwann cells 0. And you can see that the allograft has been completely resorbed and tapers down into this little cone in this PIN reconstruction that I had to redo. So suture versus glue is another thing that I often get asked about. In this study, this rat model, using suture versus glue, 8 weeks post-repair, histologic and functional outcomes for crush injury were better. Why? Because the structure is intact, but once you cut it, suture was equivalent to glue. The key is it's the same as long as there is no tension. So we have so much more to learn, and I think we really need to stay tuned to what's going on the basic science side of nerve to understand what we're doing as clinicians on the surgical side. And for any more information, you can look at www.littlearms.org, and we have a lot of this information as well as our instructional videos on here. Thank you very much.
So Dan, I'll begin with the questions. Do you think, with reference to electrical stimulation that that everyone's starting to talk about, there's enough evidence to support intraoperative nerve stimulation to allow the growth cone to come out as a more consistent pattern?
Yeah, I think that the evidence is now strong enough. I mean, we're dealing with not if, but how at this point. So the question is, how much electrical stimulation, when, and in what form do you deliver it? I think that's more the question now.
And then the second thing, Brushhart's been working on this for umpteen years. If the problem with not using a sensory nerve as a graft is we don't have many motor nerve options. Are we missing options that we should be thinking about using? So like, should we use a piece of a terminal branch of the thoracodorsal nerve, where we know there's more terminal branches, for a motor graft instead of a sensory graft?
Right. I mean, that's a very good question. I think I think the ideal, well, so looking forward, the ideal scenario, right, would be to use a conduit which has neutral, non-differentiated Schwann cells that don't select for motor or sensory. That would give you sort of the best result, because you have initial non-biased selection when the axons enter the conduit. And then at the end, when they reach the second junction, that's when there's selection based on the Schwann cells. But currently, you know, the Schwann cells that are sensory will still accept motor, but they tend to have a bias towards selecting sensory. So once an axon has entered the interneural tube, it is going to compete for any other of those little fibrils that have entered the interneural tube. So I don't, the answer to your question is I don't know, because we don't have many options. I mean, all you have is basically Searle and maybe PIN, sensory, and you know, what are you going to sacrifice? And what's it going to, because you need also the concept of a cabled graft to maintain the vascularity, or to maintain the ability for those nerves to imbibe. You need to take a small nerve. So I don't know the answer to this, Scott, and I think the reason that Brush Heart's been working on this for such a long time is because it is an unsolved problem. That's a long-winded answer.
Yeah, one more question. And is it the opposite too, meaning that if you take a motor nerve, it's less apt to accept a sensory recovery?
Yes. So those are true. Yeah. I can't tell you because I don't know. Somebody maybe does know how selective they are. Like what percentage does it block? Is it a 5% preference? Is it a 95% preference? That I don't know. Because what Hoke showed is that they will, so a sensory Schwann cell will accept a motor axon in their study. It's just that if you remove that motor and then you put sensory back in, the Schwann cell will go back to being a sensory preference. Yeah.
Yeah. And maybe Shufeng can comment, but you know, we did a fair amount of vascularized ulnar nerve graft when we started doing contralateral C7s.
Right.
I mean, you would think that would be the ultimate combination of sensory and motor Schwann cells, yet the results were somewhat disappointing.
Yeah, that's true.
Yeah.
And it may be because of the length, and also the vascularity of it may not be what we thought it was.
Yeah.
Yeah. Any other?
But one more question that says, what would you suggest to maximize muscle reinnervation?
Yeah, I mean, that's what we've been talking about, right? I think the biggest thing is, you know, we talk about nerve grafting. One of the advantages of nerve transfers, right, is that you are taking preferentially motor. And I didn't get to this in my talk because I ran out of time. I was a little long-winded. But if you look at the percentage of a motor neuron, it's about 50% efferent. So even still, when you look at a pure motor nerve, you're not going to get 100% motor fibers. So I think the best muscle reinnervation occurs from the highest percentage of motor fibers that you can put as close to the end plate as possible, and that's via nerve transfer.
And then Jessica had a question about MRI tractography. Is that helpful to delineate nerve injury?
You know, I don't know enough about that, honestly. And then I think Ramiz has a question of using allograft, right? So the whole point, and I was just about to get to this in my talk, the whole point of using allograft is exactly what you're saying, is that you don't have any preference for motor or sensory. You just provide a conduit which has endoneurial tubes intact. The downside of using these conduits, or these allograft conduits, is that you don't have Schwann cells inside. And that's not just important for supporting the outgrowth and attracting these growth cones of the axons, but it's also important for maintaining the structural integrity of the allograft itself. Because in the end, you're in a race between macrophages trying to gobble up and destroy your allograft, and Schwann cells that are moving in and stabilizing that allograft. And so that is why allografts after about 1.5 centimeters don't do as well as autograft. So allograft is not the answer either, but maybe the answer in the future is an allograft with spiked sensory and motor Schwann cells that are stippled throughout it. And I'm not sure how technically you would do that.
Last comment, I love the analogy that when we teach our residents and fellows, if we're running a marathon and you have all these water stations, think of them as the Schwann cells. And if you don't stop for water and get a drink of water, you're not going to make it to the end of the marathon. So Schwann cells are just critically important for nerve regeneration. And I think the problem with the allograft, like I said, there's no Schwann cells, there's no water stations, and they poop out after a centimeter or so. I think it's critical to understand that for a mixed peripheral nerve injury, allograft is clearly a second choice. Chesko, any other comments?
Just, I have the idea that the nerve regeneration is similar between children and adults, but the difference in the outcomes is because of the brain. Is that true? Does the current science supports that the difference is not in regeneration, but the brain capacity?
I think it's a combination of the two. So there's a lot of things that are happening in child that don't happen in adults. One of them is cortical pruning, right? But the other one is pruning of lower motor neurons. That doesn't happen as much in adults as it happens in children. The nerves tend to be more stable. So you have this sort of fight between the stability of an adult neurologic system versus the plasticity of a pediatric neurologic system. And they both have their advantages. And I think the clear winner is plasticity over stability, right? But it's a combination of what's going on in the brain, what's going on in the spinal cord, and what's going on in the peripheral nerve. And it has to do also with Schwann cells after a certain amount of time will not support regeneration. Schwann cells actually become permanently phagocytic cells after a certain amount of time, and they don't go back to being remyelinating. They transform back into these non-remyelinating cells.
Thank you.
Yep.
Thank you for watching. For more videos like this, please see our YouTube channel, Little Arms, as well as our webpage, www.littlearms.org.